Hello everyone, this is Dr. McDonough and we're going to start the summer semester talking about goniometry. Goniometry is something that you'll become an expert in by the end of this summer and you're going to learn so much. So sit back, listen, take some notes, and then we'll discuss again in class as well with any questions that you may have. So what is goniometry? Goniometry actually comes from two Greek words, gonia meaning angle and metron meaning measure. So when we talk about goniometry, it is the measurement of angles created at our joints in our body. We will actually align our goniometer up on specific landmarks on the bones that you've just learned in anatomy, and we'll measure the angles that these bones make with each other as the body moves. So where, when, why, and how is goniometry used? It is used as an assessment tool that the PT will first do during the evaluation. They're going to look at the arc of motion or the range of motion between the proximal and distal segments of the bone to see what that angle is. It'll be used to show if there's an impairment. If a patient is lacking range of motion, that will be on their impairment list. And you've already learned in Thorax course some stretches in order how to increase that range of motion, or maybe a joint mobilization. It also is a measurement that we can show progress. If the PT takes these measurements on initial eval, then as a PTA you can follow up with these measurements and show progress that patient has been making. It also allows the clinician to get some feedback on that patient's willingness to move. We'll start to talk about end feels and being able to tell maybe if the patient has a lot of pain or if they are anxious for movement, and you'll be able to qualify that in your note as well. As I said, with the PT doing these during evals, it'll help to come up with a diagnosis, trying to determine between tendon and ligament. Also, range of motion is used when an orthotist is fabricating orthotics or when they're making a prosthetic for a patient as well. This semester, we will also review the arthrokinematics of movement of a joint. This is where we talk about the roll, the glide, or the spin. The glide that is exactly it, gliding of one surface over another. The roll is rotary in motion, and it's going to move in angular motion with the bone. We'll talk more about this. And then the spin also is rotary motion, and this one really specifically pertains to the head of the radius as it rotates. So also you learned last semester the convex-concave rule. Does anybody remember that rule? Well, let's review it. So if we're talking about our two joint surfaces, and I want everyone at home to go ahead and we'll talk about the shoulder. So let's use your right arm to make your head of your humerus, and then go ahead and use your left hand to cap over it and have your like the acetabulum, or the glenoid fossa. So what we're going to do is go ahead and let's do shoulder abduction. So your arm is going to go out to the side, and we're going to pay attention. So when we look at this, the roll is going to be in what direction? As you move your arm into abduction, you are going to have an superior roll. Just like you can look at your arm, your arm is moving superiorly, so is the roll. And then if we look at the glide, or if we continue to roll superiorly, we're going to be jamming our humeral head up against the glenoid fossa. So what has to happen, then we have to have a glide, and so then the glide is going to be inferior to allow for that to stay on the joint surface, the articulating surface. So if we look at the convex-concave rule, if we have, like what we have here, we have a convex surface, the humeral head moving on concave, that means that the glide and the roll are going to be in opposite directions. If we have a concave surface moving on convex, if we think about the knee joint, then we are going to have the roll and the glide in the same direction. As a reminder, the roll is always going to follow the direction if you look at the distal bone. So if we're looking at knee extension, we're going to have, if we go into knee extension, we're going to have a roll that is superior. So we'll talk more examples about this in class, but go ahead and please review the convex-concave rule, because throughout the semester with each new joint, we will discuss the arthrokinematics. And you may say, why do we want to discuss the arthrokinematics? We want to make sure that we understand so that when you need to do a joint mobilization, you know which direction you need to move. Okay. We will also be discussing osteokinematics. And the osteokinematics is the gross movement of the shafts of the bones and the angles that they move. This is what we will actually be measuring when we use our goniometer. We are unable to measure the small movements that occur with arthrokinematics. Again, the importance of knowing the arthrokinematics is for doing joint mobilizations and having an understanding of why there might be limitation in the joint. But when we talk about range of motion, we are going to be measuring osteokinematics. And you see there on the slide too, we can measure range in the sagittal, frontal, or transverse plane. So just give an example, if we take the shoulder, the sagittal will be measuring shoulder flexion, the frontal will be measuring abduction, and the transverse could be internal and external rotation. So in goniometry, we are going to be measuring a range of motion, or the arc of motion that occurs at the joint or series of joints. I want to point out that the starting position for all range of motion measurements, except for rotations, is going to be an anatomical position. So go ahead and review what anatomical position is. Put yourself in that position. So it's a review for you. We will also be utilizing a degree system of 0 to 180 degrees. I don't think anyone can do a 360-degree rotation of their head or of their arm. So yes, we will be using between 0 and 180 degrees. So if we're talking about starting at anatomical position, except again for the rotations, all the other joints in the body are at 0 degrees in that position. So you see some examples listed there. In anatomical position, you're in 0 degrees of flexion or extension of the hip and of the knee. When you review in your textbook, you will see that there may be several norm values listed. We will use the American Academy of Orthopedic Surgeons as our norm value. Let me repeat that again. When you are reviewing in the textbook, our standard that we will use for norm values of range of motion is the American Academy of Orthopedic Surgeons. We can measure a range of motion both actively and passively. So as a reminder, if it is active range of motion, the motion is totally performed by the patient without assistance from the PT or PTA. Passive range of motion would mean that the patient is exactly that. They are passive, and the PT or the PTA is moving the limb while they are measuring the joint angle of motion. It is very important to determine whether your measurement is active or passive, and can give you lots of information. So for example, if the patient has full active range of motion, you have them move their shoulder in all directions and you can tell that it is full, there is no need to then measure it passively if they have the muscle strength and the range within the joints to do it actively. It's also important sometimes though to do both active and passive. Say for example, you are measuring range of motion of the hip and it is painful and the patient is stopping and it is due to pain. You can then measure it passively, and if there is no pain, then you know that it is contractile tissue which is causing the problem, so muscle or tendon. If it is painful, both when you move it, when they move it actively by themselves and you move it passively, then you start to think of it as being inert or non-contractile tissue. Maybe it is ligament, maybe it is the joint surfaces itself. So this can really be a great screening tool. And then also, what is the other type of range of motion that you've talked about? Active assisted, correct? We typically do not measure range in active assisted. Usually we measure it only actively and passively. In addition to measuring the joint angle, we will also be assessing the end feel, which is what is the sensation, or what do you feel when you are passively moving a patient at the end of their motion. There are 3 different end feels that can be normal. You can have a soft end feel, and this is where you are restricted by motion because of soft tissue approximation. Some great examples of this would be with knee flexion, where your calf may come in contact with your hamstrings and prevent further knee flexion. You can also think of it with elbow flexion, where we're going to have the forearm muscles with the biceps. So you might be able to feel that on yourself here at home, or maybe see if you can see someone in the house and just go ahead and feel what that feel is, giving them a little bit of pressure, that full range, and feel what that means to be soft. We also can have a firm end field, and what makes it firm is that either there's a muscular stretch, capsule, or ligament stretch. So there's your example of looking at hip flexion with a straight knee, and also we could think of so what are we looking at with that muscle? If we look at hip flexion, which muscle would be put on stretch? That's right, the hamstrings, so that you would be feeling that firm end feel. You can also just try it while you're sitting here listening, is looking at trying to do extension at the MCP joint in your finger. And you can feel that capsular tension, or possibly some even flexor tendon restriction. And then if we think about ligamentous stretch too, another example is if we do forearm supination. So try those on yourself, or if there's somebody at home that you could feel what a normal end field. And an example of a hard end field that's normal, so that's when you have bone on bone contact, would be if you were to do elbow extension, and that's with the olecranon meeting up with the humerus. So that's a hard end feel. We will also practice these when we get into lab, but this gives you a good understanding of 3 different types of end feel, all of which can be normal. It will be important to know which is the normal end feel for each joint and each motion at its end of motion. Because you see on this slide with the abnormal end feels, soft, firm, and harder, all listed again, but it just depends that it's occurring when it shouldn't be occurring. So if you have a soft end field when you are expecting a firm end field, you may think that there is some edema there or some inflammation of the synovium. If you have a firm and it's occurring sooner in the range than you think, it could be that there is some muscle tightness, or just the ones that are giving the resistance, muscular, capsular, or ligament, that there might be some tightening or shortening of those structures that now are restricting the range of motion and giving you a firm end field before you should be feeling it. Excuse me. You can have a hard end feel, and that may be that there is a loose body, maybe there's a small fracture that has occurred, and it's now floating within that joint space and can block the motion as it's floating through. An empty end feel is exactly that. You feel nothing, it's empty. And a lot of times this is going to be because of the patient having pain, fear, or anxiety, where they're going to stop you in the motion before you get to the end range. So it would be very important, if you are measuring range of motion and it is an empty end field, for you to note that. So you're going to note what the range is, as well as that it was empty. If you measure a patient's range of motion and doing this passively, and it is less than what you expect as the normal range, then we could say that that patient has a hypomobile joint, or they have hypomobility. So again, if we're doing passive range of motion and you feel at the end feel early and it is not a normal range that you are expecting, that patient would be hypomobile. There is what we call a capsular pattern, and that was created by Cyriax, is showing that when the joint capsule itself is the reason or the pathology as why the joint range of motion is limited. What was determined by Cyriax is that there is a pattern. So if the joint capsule is the pathology, there is a pattern of restriction. And it is not necessarily that they are limiting a certain number of degrees, but they are going to be limited more in flexion than extension. So each joint has been mapped out with a pattern, and you see that it's in your textbook by Norkin and White on page 11 that shows all of the capsular patterns. We will discuss in class which of these patterns are important for you to know and remember. Also, if you're measuring range of motion, if you have an increased amount of passive range of motion, meaning that there is more motion than what is considered in the normal value, then that patient would have a hypermobile joint. Or if it occurs through several, you might say that that patient has hypermobility. There are some diagnoses or pathologies which this occurs more frequently. Two examples listed are Down syndrome and Marfan syndrome, so that there's a laxity within the soft tissues. You can also see this maybe after someone has had an ankle sprain or repeated ankle sprains, and they don't have that stability in their ankle anymore. You could say that their ankle is hypermobile. Some people are naturally more hypermobile than others. So what I'd like for you to do is look at the hypermobility score on page 12 in your textbook by Norkin and White, and go through and see how you rate. And then we'll refer in class and see who has higher hypermobility scores, and we'll take a look. There are other factors that can also affect range of motion, and not necessarily have there be a pathology in the joint capsule or ligament or tendon. For example, you can be looking at a joint that has a muscle that crosses two joints. Can you think of any muscles that would cross two different joints? Well, one example is the hamstring. The hamstring is going to cross the hip joint as well as the knee joint. So when you are measuring hip or knee motion, it's going to be very important on positioning so that you take out the extra stress that is caused on that muscle or the tension on that muscle if it is being stretched at both ends. So there's a difference. Since the hamstring will extend the hip and flex the knee, if we are measuring hip flexion, right, that's going to put the stress on the hamstring. If we are measuring hip flexion, we have to allow the knee to flex so we take the tension off. It's exactly why when you are identifying to stretch the hamstring that you are going to put that knee in extension so that you are stretching that muscle at both ends of its attachments. But when we are trying to look at and assess the motion at the hip, we want to take the knee out of the equation. So that can be a factor as why you might see differences in your range of motion, is if that muscle crosses two joints. Again, we've already discussed a little bit that we can see differences in active versus passive range of motion, especially if there are contractile tissues that are at fault for limiting the range of motion. The patient can have more passive because it's being passive and they're not being painful because of that contractile tissue. You can also see just differences in having less passively than they do actively and have it be normal. Just feeling that, I'm saying that in reverse, excuse me, that if someone's putting a stretch on you, you might be able to go a little more passively than you can actively. Also, our age can play a factor. It's a normal tendency that as we get older that we lose some motion and get a little stiffer. Also, gender. Females tend to have more flexibility, more range of motion than males. We can maybe think that's considered to how muscle bound the individual is. We can also have other factors that affect body mass index. So if someone has a lot of redundant tissue and have a higher BMI, you might have limited in range of motion just because of having that soft end field. Occupational and recreational activities can also influence range of motion, maybe even making a joint hypermobile if they're repeatedly doing the same motion. If they, for their job, have to work an assembly line and reach overhead, they may tend to have more motion in that arm because of that reach that they're constantly doing. Or recreational, I tend to think of sports. If you think about that baseball pitcher, they are going to have a lot more external rotation of their shoulder because of all the pitching that they have done. We discussed on the last slide that a two-joint muscle can affect range of motion, so that when we are measuring range of motion, we have specific positions that you will learn. However, we can also use goniometry and our knowledge of anatomy to measure muscle length. So looking at the differences, you will learn that if you are measuring elbow flexion to look at joint range of motion, the patient would be in anatomical position, and then you will flex the elbow. But if we were to have our patient, say, stand up, and actually the picture is a little bit incorrect. If we had the shoulder flexed to 180 degrees and then had our patient flex the elbow, would you expect to see the same range of motion? Well, maybe yes or no, but what muscle length are we testing? Yes, we are looking at the triceps because the triceps will cross both joints. We have similar muscle length testing for the quadriceps and the hamstring, and we will be reviewing these in lab. This slide shows you different variations in goniometers depending on the joint that you are measuring and the size. So as we go through the different joints, you'll learn which goniometer is appropriate for measuring range of motion at that joint. We will complete this lab practice when you are in class, and we will be discussing what are normal end feels for each of these motions listed below. For our range of motion or goniometric measurements to be meaningful, they must both be reliable and valid. So if we talk about reliability, that is looking at the consistency of the same person measuring using the same goniometry on the same patient. This would be intra-rater reliability. So if you were to measure knee range of motion 5 times with the same goniometer, and each time you measured 0 to 85 degrees, then you would have very good intra-rater reliability. Now, since all of you are new to goniometry, if we were to look at how one person measures knee range of motion and then have another person come in and measure knee range of motion, we may get 2 very different answers. And we would say then that our inter-rater reliability is poor. And that is something that we want to work on so that if you are in the clinic and you are treating a patient, that your measurements will be reliable with the PT's measurements so that it can truly show progression. Or regression. But as you go through the semester, your reliability will improve. Validity is the tool doing what it's said to do. So if we are measuring spinal range of motion, are we getting the same range of motion that as if they were taking a radiograph, say in a flexed position? So there have been validity studies on range of motion, and yes, it is a valid tool to use. So how do you become more reliable in using the goniometer? Well, you are going to use consistent positions that are defined in your textbook. When you go out on clinical, you may see something different, and hopefully that's documented in the chart if they are measuring the range of motion in a different position so that those that follow behind can maintain consistency. But for our purposes, you will use the same position that is defined in your textbook. You will also use the same landmarks. You will palpate your landmark and be able to align your goniometer and perform the measurement. You want to think about if you are doing passive range of motion that you are using the same amount of force to get at that end range of motion. Where it might become a little bit of complicated is if your patient's in pain and how much are you going to push to get to that end range of motion. And if you're measuring it actively, is your patient giving you the same effort every time? And that's another thing that you want to encourage so that you have improved reliability. Also, use the same goniometer. And then you want to talk about the slide with the pictures of the goniometer, that you want to use the goniometer that is appropriate for that size, that area of the body. If you choose to use a large round one and it's on the wrist, you might not be able to get your measurements as accurate. If you are less experienced or as a student, you might want to take the measurement 3 times to know that you are being reliable. And then at the bottom too, you just want to practice, practice, practice. The more that you practice, the better that you will be. So what all do you need to know in order to perform goniometry accurately and reliable? You must first know the joint structure and function. Know what muscles are crossing that joint. What is this joint surfaces? What are the arthrokinematics of that joint? You also have to know what is the normal end feel. Is it firm? Is it soft? You will have to know what are the testing positions. If I am measuring shoulder flexion, what position does my patient need to be in? You will need to know your anatomical bony landmarks so that you can align your goniometer appropriately. You will have to know specifically where do I have to align it to the bony landmark. And then you have to know what is normal, what is expected when you're measuring in order to know if it's abnormal. In addition to the knowledge that you must know in order to measure goniometry, what are the skills you need to develop? You're going to have to learn how to stabilize the joint of your patient correctly so that you can get an accurate measurement. You're going to have to learn how to handle and move the body through the appropriate range of motion, as well as having the alignment of your goniometer while you are moving the patient passively. You have to be able to determine what an end field feels like and know what is firm, what is hard. You have to work on your palpation skills to make sure that you are palpating those bony landmarks that you learned in anatomy. You have to make sure that you can read your instrument correctly and then record your measurements. So this will all be part of your practical exam that you will be taking this semester. Why is positioning so important? Well, it places the joint in its starting position so that you are starting your measurement at 0 degrees. It also is in good alignment to allow for a complete range of motion. And it will also provide stabilization for the proximal joint, part of the joint that is not moving. Stabilization is the ability to fix the proximal segment to improve accuracy of motion. So if you are allowing motion, both of the distal and the proximal, then your motion, you might not gather the full range. We'll look at this in lab as well. Here's a picture again of a goniometer. You'll see that there are 3 parts to the goniometer. We have the body, or the fulcrum. The body is the round circle, and the fulcrum would actually be that center bolt that you will align on the axis. So that's called the fulcrum or the axis. And then you have a moving arm and a stationary arm. You see that the stationary arm is attached to the body, or it's attached to the circle, whereas the moving arm is not. When you are measuring range of motion and aligning your goniometer appropriately, you want to make sure that you expose the skin and actually measure the joint. Do not measure range of motion over clothes, especially clothes that are bulky, that you aren't able to get an accurate assessment. You will align the fulcrum or the axis. That is that center part of the circle of the body. And then you will have your stationary arm. It also can be referred to as the proximal arm, and the moving arm, which is often referred to as the distal arm. You will use the specific bony landmarks that are identified for measuring range of motion at each joint. So how do you read and record your goniometric measurements? You are definitely wanting to include the start and end positions, so that this is a range of motion. So you want to see something like shoulder flexion 0 to 180 degrees, not just 180 degrees. You have to have a start point and an end point. You want to document too whether it is passive or active, and rarely maybe you might see active assisted range of motion, but you want to determine which one it is. You want to check the contralateral side for comparison, and this should have been done by the PT during the eval, but why? Well, we want to make sure what is normal for this patient. So if they are coming in with a knee injury on the right, what is their left knee that is uninjured? What is its range of motion? And even though we have norm values, we might have some variability within our patients, and so you can realize what is normal for this patient. You may also have to identify whether it's a rotation or ABA deduction that you're measuring. There's a typical format used for flexion and extension, and we'll talk about these in lab, but you want to definitely identify the motion. And you can review in your textbook on page 35. So when we're looking at documentation, you see here as an example, patient demonstrates 5 to 85 degrees active range of motion right knee. Patient non-surgical left knee is 0 to 115 degrees active range of motion. You will learn that a 120 degrees is what is considered normal value, but by comparing the involved side to the uninvolved, you see that the patient normally lacks 5 degrees of knee flexion. You may say, well, they didn't identify the motion. Well, because the knee is a hinge joint that only moves into flexion and extension, it is a given that this would be a measurement for flexion and extension. You also may be wondering, why is it starting at 5? Dr. McDonough says we will start in the anatomical position, and 0 degrees is anatomical position. Well, this patient isn't able to achieve the anatomical position. When they lay out flat, their knee is still a little bit flexed. So they are unable to achieve 0 degrees of flexion. So when it starts at a 5, you know that that patient is starting in flexion and they are lacking extension. When you go out in the clinic, you may see something documented just saying 85 degrees of right knee flexion. This is going to be incorrect. I want you to be in a routine of documenting a range. In this course, everything will be documented in a range, and if not, it will be incorrect. So get used to using and showing the range. And we will obviously have a lot more practice with this in lab. Well, this was your introduction to goniometry. I'm glad that you reviewed this before coming to class so we can have a lot more hands-on time and practice with the goniometer. See you in class.